Hi, everyone. We'll get started in just one moment. Okay, we'll go ahead and get started. Hello, everyone. Thank you for joining us today. I'm Bethany Burkhart, the Director of Operations at Allergy and Asthma Network. I'm excited to welcome you to this afternoon's webinar. We have a great session planned, and I'm pleased to introduce our presenter, Dr. Theresa Bingemann. With her extensive knowledge of allergy and immunology, we can look forward to an enlightening session. Before we begin today's program, I'd like to cover a few housekeeping details. First of all, attendees will remain muted during the webinar to minimize distractions. We will record the session and upload it to the website later this week. You can access all of our recorded webinars at allergyasthmanetwork.org. Scroll to the bottom of the page to access past webinars and future events. Our webinar is scheduled to last 1 hour and will include a dedicated Q&A segment. Although we will answer questions at the end, please feel free to submit them at this time using the Q&A box at the bottom of the screen. A team member will monitor the chat for any questions or assistance you may need. We will do our best to address as many questions as possible before we conclude. This Advances webinar is brought to you in collaboration with the American College of Allergy and Asthma and Immunology. ACAAI offers the continuing medical education credits, CME credits, physicians and attendees credits for others. You can create your ACAAI account to earn CME or attendance credits for Advances webinars via the member portal. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after the webinar, you will receive an email containing supplemental information and a link to download your certificate. We will also share the link to the certificate in the chat. So let's get started. Today's presentation is titled Anaphylaxis, the Changing Treatment Landscape. Between 1.6 and 5.1 of people in the United States have experienced at least one anaphylactic episode, with certain foods, medications, and insect stings being the most common triggers. Anaphylaxis is a severe allergic reaction requiring a timely epinephrine treatment for survival. Recent studies indicate that nearly 1 in 50 Americans has experienced life-threatening allergic reaction. In this webinar, Dr. Theresa Bingemann will discuss the current guidelines, emerging therapies, and evidence-based approaches to improving patient outcomes. We will offer practical insights on the acute treatment prevention of anaphylaxis in the evolving landscape of its management. It's a pleasure for me to introduce our speaker. Dr. Bingemann attended Rutgers University and earned her medical degree at the University of Medicine and Dentistry in New Jersey, Rutgers Medical School. She then completed a combined internal medicine pediatrics residency at Mount Sinai. She then completed an allergy and immunology fellowship at Mayo Clinic. Dr. Bingemann is an associate professor of pediatrics and medicine at the University of Rochester, where she is a program director of the Allergy and Immunology Fellowship. She is actively involved in teaching fellow residents and medical students. Dr. Bingemann is a fellow at FACAAI and the American College of Allergy and Asthma and Immunology and the American Academy of Pediatrics. She serves as an editorial board for the Annals of Allergy and Asthma and Immunology and a reviewer for several other journals. Dr. Bingemann serves as the American Board of Allergy and Immunology Board of Directors in the ACGME Allergy and Immunology Review Committee. Wow. She's an active member of several committees in the ACAAI and QuadAI. Her research focuses on IgE and non-IgE medicated food allergies, anaphylaxis, and physicians' well-being. Okay, thank you for being here, Dr. Bingemann. I'm going to turn it over to you, and then we'll have a quick question and answer at the end.
Thank you so much for having me. It's a pleasure to be here. And thank you to all of you that are participating for being here to talk about It's a really important topic. These are my disclosures. So I'm hoping during the next hour, we can differentiate anaphylaxis from other acute allergic reactions and justify the use of epinephrine as first-line therapy based on clinical guidelines. We will also analyze patient and system-level barriers to timely epinephrine administration and evaluate strategies to overcome them in clinical practice. Lastly, we will appraise emerging therapeutic modalities for anaphylaxis management, including non-injectable delivery systems, and integrate them into patient-specific treatment planning. So let's start out with what is anaphylaxis? Anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. Typically, this has multi-organ involvement. And what you see on the right here is the array of signs and symptoms that may occur. So patients may report dizziness, faintness, you might see loss of consciousness, someone might complain of an itchy mouth, hoarse voice, lip swelling, congestion, sneezing. There might be difficulty breathing. There can be GI symptoms like cramps, nausea, and vomiting. The most common symptoms are the skin findings, which occur about 90% of the time, which is rash or hives. And then, of course, we can have swelling of different areas as well. Anaphylaxis has been estimated to occur in up to 5% of the overall population. And one of the most challenging and possibly frustrating things for patients and physicians alike are that at least a third of the cases occur without an identifiable cause. So there are a variety of triggers of anaphylaxis, including foods, and the most common foods, of course, are peanuts, tree nuts, fish, shellfish, milk, egg, soy, wheat, and sesame. And but it's important to remember that any food can be an allergen. The stinging insects are can be an allergen, as well as antibiotics and things we give in the hospital. Latex allergy is less commonly seen, but we can see occupational allergens, and we can see problems after radio contrast media. Anaphylaxis has been on the rise, and overall, the rate of anaphylaxis per 100,000 has increased by 101% from 14.2 in 2005 to 28.6 in 2014. The greatest increase has occurred in children aged 5 to 17. In addition to an increase in food-related anaphylaxis, medication-related anaphylaxis has also increased substantially. So then now let's look at the rates of anaphylaxis according to age. And we're looking at on the y-axis per 100,000 person years. And on the x-axis, we're looking at ages from babies on the left to the elderly on the right. And you see the largest group in the young kids under 4 are related to food, then drugs, and then idiopathic causes. As you get older, you see more and more related to drugs, and you see this array of idiopathic causes all along. Anisakis is a fish parasite that people can have reactions to as well. This is most commonly described in Europe, but this can occur anywhere. So then where is anaphylaxis occurring? And as a parent or a caregiver, it can be very stressful to send your child out of the home whether that's to school or to camp. And it's important important to recognize that the majority of anaphylactic reactions actually occur in the home. And this is true for both children and adults, and in those studies where age wasn't specified, followed by for kids in another person's home, and then school, and then or a restaurant. And you see there's more reactions for adults in restaurants than kids. I always like to remind everyone that epinephrine is first line for the treatment of anaphylaxis. And as I tried to demonstrate on the previous slide, this can happen anywhere. So it's always important to have epinephrine with you. And there's good data to show that early use of epinephrine can improve outcomes. In fact, using epinephrine early is associated with a decreased need for additional doses of epinephrine. It reduces biphasic anaphylaxis. Biphasic anaphylaxis is when you have an episode of anaphylaxis, your symptoms completely resolve, and typically between a few hours to 24 hours, the symptoms start up again. Early epinephrine can also reduce hospitalization as well as fatalities. So, what are the factors that increase the risk for severe, near fatal, or fatal anaphylaxis? Well, they're listed here, which includes the delay in the use of epinephrine, the severity of the reaction, the absence of urticaria. And the reason this is an issue is because oftentimes, in the absence of urticaria, people don't recognize these as allergic reactions. Biphasic reactions, beta blockers and ACE inhibitors being over 65, having cardiovascular or pulmonary disease, when medication is a trigger, uncontrolled asthma, elevated tryptase or mast cell disorder, or platelet activating factor acetyl hydrolase deficiency. You'll note the only thing on here that's truly modifiable is timing of epinephrine use. It has also been shown that early use of epinephrine reduces the length of stay in the emergency department and reduces biphasic reactions. Even if that epinephrine has not been given by the individual or the caregiver, even when epinephrine is given by EMS. Unfortunately, there have been anaphylaxis fatalities, as you know, and the case fatality rate is between 0.25 and 0.33% of hospitalizations, ED presentations for anaphylaxis. So it's about 0.47 to 0.69 per million persons. And what are the risk factors for all causes except venom? Those include Black race and older age. For venom anaphylaxis, white race, older age, and male sex are risk factors for fatality. The highest risk of fatalities occurs in individuals greater or equal to 60 years old. And not surprisingly, outpatient fatal anaphylaxis is more associated with food, and drug-induced anaphylaxis is more common among hospital inpatients. So I have already mentioned that epinephrine is first line for the treatment of anaphylaxis, and we talked about the benefits of early use of epinephrine. But if you think about a reaction, these symptoms occur very quickly, typically within the first 5 minutes. And then when they've looked at studies of fatal anaphylaxis, they looked at it by cause to look at time to death. And for respiratory arrest or shock with foods, that has occurred in 30 to 35 minutes. With insect stings, approximately 10 to 15 minutes. And for drugs, less than 10 minutes. However, on average, people wait up to 18 minutes before they dose epinephrine. And so I mentioned that there's a delay in use of epinephrine, but even though people know these benefits, sometimes it's not used at all. And so, what are the reasons that epinephrine might not be used? So, in various studies, they've looked at carriage rates of epinephrine, and we found that when asked, do you always carry your epinephrine? Only approximately 46 to 67% of people always carry their epinephrine. And then, if you look at epinephrine autoinjector use by parents, this was low, about 25 to 58%. So, what are the reasons for not using epinephrine? Well, it may be because someone didn't have the medication, and that could be in general because they didn't get it at the pharmacy. Perhaps it is a cost issue. Perhaps the insurance didn't approve it. Perhaps they didn't think it was necessary. Or maybe the individual actually had epinephrine, but they didn't have it with them. Another common reason cited for not using epinephrine included not knowing when to use the medication. And it is important that we review this frequently with our patients. I find in my clinic, I often describe when to use epinephrine a few different ways because through the years, whenever I've been on call, I'll get that call saying, "Is this the right time to use my epinephrine? Can you talk me through this?" And so we give families a lot of information and it's hard to remember it all. So I often say that if you're having more than one body system and it's an acute allergic reaction, that meets the definition for anaphylaxis. If you have hives and coughing, that would meet the definition for anaphylaxis, hives and vomiting. I also tell people if someone has that deer in the headlights look or that sensation of impending doom, that's a pretty good time to use epinephrine as well. And it's important that if a reaction is progressing quickly, always use the epinephrine. The other factor is our devices can be tricky. Involve multiple steps. And oftentimes, what we prescribe and maybe even teach someone on is substituted at the pharmacy. And so that's not the device they get. And so oftentimes, people say they don't know how to use the medication, which is why they don't use it. Another common reason for not using epinephrine is that oftentimes people didn't think it was necessary. Other reasons for not using epinephrine, including needle phobia, so not wanting to stick myself or my child, not wanting to go to the ED if I used epinephrine, fear of hurting their child, or device storage concerns. So there's recommended storage temperatures on these devices. And so oftentimes people worry about bringing them out and about with them. And so it is important to always have these on the allergic individual and to use them when needed. So, what are parents and caregivers experiencing when their child is having a reaction? Well, one of the things is fear of hurting their child. In particular, if the child is very scared about using epinephrine and the child is violently jerking their legs or thrashing about. Oftentimes, if there's uncertainty about the diagnosis, I've often been asked, am I going to hurt my child if I give them epinephrine and it wasn't needed? Epinephrine is extraordinarily safe, and so when in doubt, it's safer to give the epinephrine than not. Needless to say, if a child is having a reaction, a parent that's observing this or a loved one will be experiencing some anxiety and stress. Most of us that have seen allergic reactions hope never to have to see one again. Then there may be regret or helplessness or guilt. I've often had families say to me, did I cause this? Should I have done something different? And then there's been questions about, is the device expired? If it is it safe to use? And of course, if you have a device, it's always best to have an up-to-date device. However, an expired device, unless it is discolored or has lots of particulate matter in it, is safer to use than not using epi at all. So, there have been some cases of auto-injector related injury, and some of this most typically has been in young kids that were scared. And so it has since been recommended to make sure you stabilize the limb as much as possible. Place the device on the leg as opposed to the swing and hit motion and apply pressure. And then hold the device in place for the shortest period of time recommended by the manufacturer. Importantly, if it comes out, do not reinsert the needle. So studies have also been done looking at factors associated with correct autoinjector use. And the one significant factor has been time elapsed since the last visit. So in fact, we should be making sure we're reviewing how to use an epinephrine autoinjector at least every 6 months. And you might say, well, I don't see my patients every 6 months. So I typically advise people to go to the manufacturer's website where there's often videos and step-by-step instructions. When people get new devices, you can practice on an orange with the old device to see what it's like. But it is important to review this periodically so there's no doubt when it's needed. I also find it's very helpful to explain what people can expect after using epinephrine. And this can be helpful if people have reactions in the office or if they're going to be out in the community. So, as you know, epinephrine, when you get epinephrine, it feels like you just ran a mile or had a big scare. And so it causes your heart to pump faster and harder. And this helps raise our blood pressure and move circulation throughout the body. Epinephrine also relaxes the airways and allows our breathing to become deeper and faster. It may cause the pupils to dilate, and the skin may become pale as blood is shunted to your internal organs. And I always like to point this out when I'm treating reactions in the clinic because parents can get very frightened or loved ones can become very frightened when they often see this flushed individual then become very pale. And so it's a little easier for everyone if they know what to expect. Muscles will have increased blood flow, and some people will say that they feel anxious or a little hyper. And this is to be expected. I describe this is a sign that it's working. Up until this point, I've been talking about auto-injectors, and for years, patients have wanted some other alternatives. So for the rest of the talk, I'm going to discuss some items that are currently approved and others that are in development that are currently not FDA approved. I'm going into these so you can understand what's coming down the pipeline. So the are now 2 epinephrine nasal sprays, one that is approved, that is the top one here by ARS Pharmaceuticals. The one to be developed by Bryn Pharma is still undergoing evaluation, and there's also a sublingual film that's being studied at the moment as well. So I want to take you through the studies that led to the approval of our first intranasal epinephrine. And most of these studies for all of the devices have been done in very similar ways. So for our first currently approved device, there were 4 studies in 175 healthy adults without anaphylaxis. And the reason for that is it's considered unethical to do studies in people that have anaphylaxis when we know with new drugs, when we know epinephrine works. Also, because we can't do these studies, excuse me, in people that are having anaphylaxis, what they do is they measure the epinephrine levels in the blood and they compare the levels with these new devices to the levels of the currently approved devices. So I'm going to go back to pharmacology for a second. And you may remember pharmacokinetics and pharmacodynamics. Pharmacokinetics is a study of how a drug moves through the body. It tracks absorption, distribution, metabolism, and excretion. And pharmacodynamics looks at how the drug affects the body. So this is our first figure looking at Neffy, which is an intranasal device, epinephrine given IM as compared to EpiPen and then Neffy self-administration. What you see on the y-axis is the mean plasma concentration. On the x-axis, you see time in minutes. So starting with the green, the dark green, you see the plasma concentration over time with Neffy administered by a professional versus the light green, Neffy self-administered, with the yellow being an IM injection of epinephrine versus EpiPen in blue. And you can see that a device that's an auto-injector leads to a peak concentration a little earlier. Then they looked at the plasma concentration versus time when we're looking at administering 2 doses. You know that at times a second dose of epinephrine is needed. This is why we recommend having 2 packs with an individual at all times. And what you see in the dark green is the Neffy administered twice, once in the left nostril and once in the right nostril. In the light green, they're comparing 2 administrations in the right nostril. In the yellow, they're looking at epinephrine administered by a syringe in the left leg and then the right leg. And then they look at EpiPen in blue. And in these circumstances, the intranasal epinephrine has a faster time to peak plasma concentration. That being said, the most important part is what does it do to the body? So what you're seeing here is when we administer epinephrine in any of these forms, how long does it take for us on the top to see a change in the systolic blood pressure? In the middle, a change from baseline in the diastolic blood pressure, and on the bottom, a change from baseline in heart rate. And as you know, when we administer epinephrine, we expect it to work quickly. And that's what we see here with the changes in vitals for the systolic blood pressure and the heart rate. We often tell patients if we administer epinephrine, we expect that their symptoms should improve. And if they're not, within 5 to 15 minutes, they could administer another dose. And so it's important that the medicines are working in that time frame. Interestingly, if you look at the middle of the slide, in injections have been associated with a drop in diastolic pressure, which isn't seen with the nasal devices. So, what else do they have to do to get intranasal epinephrine approved? Well, most patients with anaphylactic allergies may also have environmental allergies, or like anyone else, they might get a viral upper respiratory tract infection. So, if we're going to treat someone with nasal epinephrine, it's important to know that if they're congested, this will work. And so an upper respiratory tract infection had minimal impact on absorption of the epinephrine. There was also allergen challenges where those with seasonal allergies were exposed to their allergen. They developed congestion, and they also didn't have significant impact on absorption. And this is important because, as I mentioned earlier, congestion might be seen as part of an allergic reaction. The group that there's a warning label on for intranasal epinephrine is for those that have had previous nasal surgery or those that may have nasal polyps. This is based on lack of studies and also the possibility that this might impact absorption. So, what are the potential benefits of a needle-free device? Well, they're easier and less complicated to use. They're less painful. This may eliminate harm from errors. And hopefully, people will be more likely to use these. And in an ideal world, these devices would be used faster. So I want to take you through how to use the currently approved nasal spray. Now, each of the devices has one dose in it, so you don't want to test spray it. So the device used for the currently approved intranasal spray is the same device that's used for Narcan. And so when you hold it, you put a finger on each side of the nozzle and you put your thumb below. You put it in the nose till your fingers touch the bottom of the nose, and then you push the plunger up. And you're doing this straight up. You're not angling to the inside or the outside of the nose, and no inhalation is required. And if symptoms don't respond as expected, in 5 to 15 minutes, you can use the second device that comes in the 2-pack. Again, there's one dose in each device. So that is why we don't do a test spray. And that's why we use it and then we get rid of it and we then move on to the next dose if it is needed. For the approved intranasal epinephrine, we have 2 doses currently available. The 2 milligram dose is approved for adults and children 66 pounds and above. And the 1 milligram device is approved for children 4 years and older, 33 to 65 pounds. So, what side effects might someone see after using intranasal epinephrine? The side effects have included headaches, throat irritation, nostril irritation, and a funny feeling in the nose. People also report the signs and symptoms that I mentioned earlier related to epinephrine. This is the Brin device. This is a non-FDA approved nasal epinephrine that's still in development. And just like the previous device that I showed you, they're looking at the maximum concentration after one dose is administered. And in this case, they ended up doing 2 doses, one in each nostril, one in the same 2 doses in the same nostril, and they did the EpiPen as a comparator in opposite thighs. And so the blue shows the intranasal Cmax in opposite nostrils. The blue and white lines shows the intranasal device in the same nostril. And then the purple shows the EpiPen in opposite thighs. And a picture of the device is over here on the right. They then looked at a few different concentrations of the intranasal epinephrine, and they also compared that to an epinephrine autoinjector. And you can see for all of the doses other than the 4.4 milligrams that is in the blue, all of them met or exceeded the concentration in the blood as the epinephrine autoinjector. Oops. So then what about sublingual epinephrine? Sublingual epinephrine is being designed, so it goes right under the tongue, like you see this here. And it's designed so it's easy to carry around, whether it's on a wallet, in a pocket, on the purse. I've even seen little devices so it can go on the back of phones. And the idea is there'll be rapid sublingual absorption, and you don't have to worry about knowing how to use a device. And the hope is the fact that you can put this in the mouth, that it will reduce the hesitancy to use auto injectors. And so just like the other studies, what I'm showing you here, the sublingual is the AQST in the green. The manual injection of epinephrine is in the black. The EpiPen is in the blue. The generic EpiPen is in the pink, and AviQ is in the yellow. And this is showing you the geometric mean concentration of the epinephrine versus time, and you see that they all lead to significant increase in epinephrine concentration over the body. So then we look at the time. And so all of these devices, as I mentioned, were studied the same way. They looked at what was the concentration in the body and how fast did it occur. And so in this group, they were looking at the sublingual time to maximum concentration versus syringe versus an auto-injector. And the sublingual led to the fastest time to maximum epinephrine concentration. And then they also did another study showing this, that the median times to maximum concentration was fastest in this one with EpiPen, then the generic EpiPen, then the sublingual, then the AviQ, and then the manual injection. But again, these are concentrations. We look at them as a comparator, but what's most important is what happens to someone's vital signs. And so what you're looking here is on the top left, you're seeing median change in systolic blood pressure on the top. You're seeing pulse rate on the bottom left. And on the right, you're seeing heart rate. And what you can see in the green is that the sublingual epinephrine had a prompt increase in systolic blood pressure and heart rate, as well as diastolic blood pressure. These other devices also had increases. They weren't as high, but it's important to know that they all work. So, since we're putting this in the mouth, are there things that are in the mouth that could make this not work as well? So, what they did was they tried to see what happened if someone had peanut butter residue in their mouth, and then they used this sublingual film. And it turns out it didn't have a significant impact on either those pharmacokinetics or pharmacodynamics that I explained to you. And then what if it goes in the mouth and it moves around? Is that going to have a problem? And it turns out that that also did not impact the pharmacokinetics or pharmacodynamics. And the good news is there were no significant adverse events. So no talk on anaphylaxis would be complete without talking about the 2023 practice parameter update. And so this raised this idea of if epinephrine is used promptly, immediate activation of EMS may not be required if the patient experiences a prompt, complete, and durable response. Now, it's very important that this is individualized and that each patient discusses this with their physician, but the guidelines make a few suggestions here. So they say home observation following the first dose may be possible if the symptoms resolve within minutes of administration, they don't recur, or the patient is asymptomatic. It's important that they have another device and they can be monitored and that they could get to emergency care if needed. In the yellow, it says consider EMS activation and possibly a second dose of epinephrine, but may continue to observe at home if comfortable. And in this case, they're saying you gave the epinephrine and the symptoms are resolving within minutes of improving or resolving, but you might have a mild persistence of globus sensation, nausea, coughing, stomach ache, and the symptoms are improving and definitely not worsening. And they shouldn't last for more than 10 to 20 minutes. So a lot of this is individualized. You need to think about what the patient is comfortable with. And we're going to talk about some other risk benefits on the next slide. However, in red here, you want to activate EMS immediately and consider second dose of epinephrine and do not observe at home if someone's experienced the symptoms are not resolving, they're experiencing respiratory distress, stridor, altered consciousness, cardiovascular instability, cyanosis, incontinence is not typical for their age. And so very important that if we don't have improvement, we seek emergency medical care. So when we're having this discussion about should we allow someone to stay at home or not, what things might we want to consider? Well, first, of course, is patient comfort. If they're not comfortable, they should go seek emergency care. Other thing is, do they have epinephrine available? And do they have another dose available? If someone doesn't have epinephrine available or they're alone, they should probably seek emergency care. You also need to ensure that the individual has a clear understanding of symptoms. If they don't understand what symptoms require the use of epinephrine, that person, if they suspect having a reaction, probably should seek emergency care. In addition to possibly stay at home, you need to understand how to use the device and be willing to use the device. And they must understand the benefits of early treatment. If someone says, I won't treat myself, that person needs to activate emergency care immediately. And we need to know that the individual, if we're considering having them stay at home, is that they've adhered to previous treatment recommendations. And I would say that someone that has a history of severe or near fatal anaphylaxis should always seek emergency care. So there's this question that I get all the time is which device is best? And in my opinion, the device that is best is the one that they can get, that they're willing to take, they know how to use, and are willing to use. I talked to you about several different devices today, and I can tell you that I have three sons. One of my sons hates having anything in his nose. And so when we've talked about getting the influenza vaccine, he said his entire life, I will take a shot over anything in my nose. My other two sons would take something in their nose over a shot any day. And so I share this with you is that not everyone is going to want the same thing. We want people to be able to have their medicines, carry it with them, understand how to use it, and use it in the case of an anaphylactic emergency. Mentioned this earlier, but I think it's extraordinarily important that no matter what device someone has, it doesn't work if they do not have it with them and they do not use it. And so make sure patients understand their emergency plan and review it at least every 6 months. If they're not coming into the office, they can set reminders on their phone to review and to practice. And in summary, epinephrine remains the first line of treatment for anaphylaxis. Nasal epinephrine is now approved and has demonstrated safety and effectiveness. New formulations of epinephrine are currently being developed, and it's important to have a shared decision-making conversation between patient and physician regarding home monitoring. But this may not be appropriate for everyone. It's nice now that this might help with I did not use my epinephrine because I don't want to go to the emergency department. However, if treatment is not durable and occurring as expected, please make sure they activate EMS. So thank you so much for listening. I hope you found this helpful, and I am happy to answer any questions.
Thank you so much, Dr. Bingemann, for that wonderful talk today. Thank you so much. I have a few questions from the chat and from our Q&A box. Please feel free to put some more questions in there, attendees. The first question today would be, would sublingual medication be suitable for children?
So I'm not sure yet what age it's going to be approved down to. It may be, what I do at present, with some of the meds I use for antiemetics, I do use sublingual formulations, but I have parents rub it on the buccal mucosa. That is well known and has been shown to be effective. However, I'm not sure if that will work for the sublingual formulations or not. So we're going to have to see what age it's studied down to and approved.
Wow, thank you. Okay, so the next question we have is, what would you consider hypotension among adolescents, since this age group typically has a lower BP at baseline?
So most of the time, and that's a great question, and I think the challenge is um, knowing what their baseline is. So most people will say 20 to 30 millimeters of mercury below their baseline. Another way to look at it is those surrogate markers of, are they dizzy? Do they feel woozy? Are they gonna fall over?
Great, thank you. Okay, another question. How common are biphasic reactions?
So biphasic reactions are pretty infrequent. They actually occur in the single digits. The hardest part about this is that each study you look at is a little different than the other one. You know, it's interesting. There is one study that looked at biphasic reactions, and they said they were more common when the allergen wasn't known. And I often think when I hear that was it really a biphasic reaction or were they exposed to the allergen again? We don't know, but overall, it's thought that biphasic reactions are in the single digits.
Thank you. This was a question. Is repeat Neffy given in the same nostril as the first dose or the other nostril?
Great question. So repeat Neffy is given in the same nostril. Their technology actually breaks down the cellular barriers. So by using it, it opens things up more and it is well absorbed in the same nostril.
Thank you. Okay, we'll do one more. Are biphasic reactions related to delayed absorption of allergenic food, especially uh, allergens?
So there's a lot we don't know about biphasic reactions. We can see biphasic reactions not only with foods, but with insect stings and with medications. So I don't think it's related to delayed absorption because the other ones are injected immediately and they're typically going right into the bloodstream. But admittedly, there's a lot we don't know in that area as well.
Okay, thank you. So that covers today's presentation. It was fantastic. Thank you so much, Dr. Bingaman. Um, it was informative and for answering so many of our questions. In a few days, Zoom will email you a link to the recording, an evaluation, and supplemental resources. And I'd like to introduce a couple more webinars we have. Another CME webinar we are thrilled to announce. The webinar will be July 17th at 4 p.m. Eastern Time for another engaging and informative advances webinar on asthma and pregnancy, a special consideration for expectant mothers with Dr. Carla Adams. We will discuss critical insights into physiological changes of pregnancy that impact asthma control, evidence-based treatment strategies, and practical approaches for educating and supporting expectant mothers. Now that's a CME webinar. And then we have a Back to School with Food Allergies webinar on July 22nd at 4 p.m. Eastern Time. This session will include discussions on 504 plans with Dr. Laurel and with Dr. Bernetti, for parents and caregivers with the tools they need to navigate the school system, a community of effective school staff, and advocate for their children's health rights. So we're really looking forward to July, and today was a great session. Thank you once again from all of us at Allergy and Asthma Network, where we strive daily to be your trusted resource for people with allergies, asthma, and related conditions.
Thank you for having me.
Yes, great. Thank you. Have a great rest of your afternoon, everyone.